Hello everyone, this is Dr. Govind Rai Garg. In this video, we will discuss about antimicrobial agents. As the name tells, antimicrobial. So these are the drugs against microorganisms. Now we can classify the antimicrobials into different parts by various methods. The classification can be, the drug may be bactericidal or static, depending upon whether they kill the organism. Cidal means kill, or static means inhibit the growth of microorganisms. In a normal person, whether the drug is cidal or the drug is static doesn't matter, because a normal person has good immune system. If we give a drug and it inhibits the growth of microorganism, and rest of the work can be done by immunity. But the problem occurs in a person with immunosuppression, like a patient with HIV. Here immunity is lowered, so that means if a drug inhibits the growth of bacteria, even now the normal immunity cannot handle that bacteria. So in an immunocompromised person, only cidal drug should be used. So cidal drug should be used in immunocompromised person. And the important cidal drugs you can remember from the mnemonic बेवफा. So in Hindi you can remember बेवफा, अनफेथफुल. सो बेवफा मार डालेगी, तो बेवफा और मार डालने वाली दवाइयां, दैट मीन साइडल ड्रग्स. एंड दिस यू कैन रिमेंबर. BE स्टैंड फॉर बीटा लैक्टम्स. BE इज बीटा लैक्टम्स. VA इज वैंकोमाइसिन. F is fluoroquinolone and A is aminoglycosides. These are the major cidal group of drugs. Okay. Then we can classify the drugs based on type of microorganism they kill. Like we can classify them as antibacterial, antifungal, antiviral, antimalarial. So depending upon type of organism they attack. Then we can classify them based on chemical structure. Chemical structure as is given in your books. In chemical structure basis, the drugs may be like beta lactams, aminoglycoside, sulfonamides, depending upon their chemical structure. Then we can classify them based on their source of origin, from where we have obtained them. The major classification here is into antibiotics and non-antibiotics. So basically, antibiotics are those antimicrobials which are obtained from microorganism. So that means when we obtain a drug from one microorganism and try to kill some other microorganism, then it is called as antibiotic. If we obtain from plants or from some synthetic method, then it is called as non-antibiotic. That means if we do not obtain from microorganism, then it is called as non-antibiotic. So remember, antimicrobial and antibiotic are not same. All antibiotics are antimicrobials, but all antimicrobials are not antibiotics. Clear? Then we can classify them based on mechanism of action. So this we need to know in detail, because for MCQs most of the questions are asked on mechanism of action. So we will discuss this classification. We will adopt this classification for all the antimicrobial drugs based on their mechanism of action. Okay. Now depending upon their mechanism, if we see from outside to inside the cell, this is cell membrane of the cell. Outside the cell membrane there is cell wall in the bacteria. Then inside we have nucleus. Here nucleus is present, which contains a DNA is present in the nucleus. Protein synthesis is occurring here. Protein synthesis is occurring because of DNA. Then we have metabolism going on in the cytoplasm. Metabolism is occurring here. So if we go from outside to inside, the drug from outermost area, we can say the drug may affect the cell wall synthesis. The drugs may affect cell wall. Then if we go slight inside, the drug may affect membranes. Drug may affect membranes, plasma membrane. Then if we go further inside, the drug may affect the metabolism. Drugs affecting metabolism. Further inside, the drug may act on DNA. Drug affecting DNA. And lastly, the drug may affect protein synthesis. So we will discuss these 5 mechanisms of antimicrobial drugs: drugs affecting cell wall synthesis, drugs affecting the membranes, drugs affecting metabolism, drug affecting DNA, and lastly the drugs inhibiting protein synthesis. So we'll discuss these one by one. In this video we will target mainly the drugs affecting cell wall synthesis. Okay. Cell wall synthesis inhibitors. From the mnemonic you can remember: firmly bind to bacterial cell wall. So the mnemonic says that these drugs firmly bind to bacterial cell wall. That means they inhibit cell wall synthesis. And the drugs are F for phosphomycin, BI stand for beta lactams, BAC stand for bacitracin, C stand for cycloserine, and VA stand for vancomycin. So this is one of the very commonly asked question: which of the following drug act by inhibiting cell wall synthesis, or which of the following drug do not inhibit cell wall synthesis? So you need to remember these 5 names: phosphomycin, beta lactams, bacitracin, cycloserine, and vancomycin. So first we will discuss about these drugs in detail. So starting with phosphomycin, it is mainly used for urinary tract infections. Phosphomycin is used for urinary tract infections. Then cycloserine is mainly used in tuberculosis. We'll discuss more details when we will discuss antimicrobacterial drugs. Cycloserine used for tuberculosis. Here remember just one important point: it causes neuropsychiatric side effects. Then bacitracin, it is used mainly for this clinically. It is not used systemically. It is mainly used topically. Mainly used, particularly infections like MRSA can be prevented. So for prevention of MRSA infection, we have creams or for the nasal carriage. Okay. Apart from bacitracin, one more drug which is used for nasal carriage of MRSA is mupirocin. Mupirocin is not of this group, but it is used for MRSA prophylaxis. We are using for nasal carriages. Okay. Then 2 drugs are left. One is beta lactam, second is vancomycin. We need to know them in great detail. So we will first discuss beta lactams, and then lastly we will discuss vancomycin. So starting with beta lactams. Beta lactam is actually a chemical name. So there is a ring called as beta lactam ring. So this is a beta lactam ring. So any drug having that chemical structure is called beta lactam antibiotics, and most of the beta lactams, they have one more ring. Based on this second ring, we have different names of beta lactams. All beta lactams will have beta lactam ring, but second ring will be different and different. And 4 major group of beta lactams we have penicillins, cephalosporins, carbapenems, and monobactams. So 4 major group of beta lactam drugs are penicillin, cephalosporins, carbapenems, and monobactams. All of them have beta lactam ring, same beta lactam ring, but this second ring is different in different drugs. So penicillins will have second different ring, cephalosporins have different ring, carbapenem have different ring, and monobactam, the name itself tells mono. They have only one ring. They do not have the second ring. They have only beta lactam ring. So this is a chemical classification basically. So we'll discuss these drugs one by one, starting from penicillins. Okay. The oldest penicillin we use is penicillin G, the first formed penicillin. So it is oldest one. So हम इज्जत से बुलाते हैं G कह के इसको, penicillin G. Penicillin G, actually the chemical name is benzyl penicillin. Now this penicillin had lot of limitations. बहुत सारी problem थी. So one by one we will discuss what were the limitations and how we overcome those limitations. The first and the most important problem was it was not effective orally. Mostly penicillin G was not effective orally because the acid in the stomach breaks it down. It is broken by acid. It was acid labile, so it cannot be given orally. Second problem was it has short duration of action. It was very quickly secreted by tubules, so it goes out of the body, the action finishes. So we need to give several injections per day. Cannot be given orally. Injection is required, and it need to be given several times a day because of short action. So the problem become bigger. We need to give several injections per day. Then it had narrow spectrum. It was mainly effective against gram-positive bacteria. Mostly for gram-positive bacteria. Many gram-negative bacteria cannot be killed. Narrow spectrum was there. Then even those gram-positive bacteria which were sensitive initially, they start becoming resistant. So resistance was developed to this drug. And most important problem which is left is many people are allergic to penicillins and they may develop even anaphylactic shock with this drug. So these were the 5 major problems with penicillin G. So now we will try to discuss how we can overcome this. Starting with first problem, it was not effective orally, and we discussed the reason. It was broken by acid in the stomach. So we developed the newer drugs which cannot be broken by acid in the stomach. So they are called acid resistant penicillins. Because they are acid resistant, so they can be given orally. So the new penicillins we develop, they are called as acid resistant penicillins, or simply we can say oral penicillins. Oral penicillin. And you can remember these very easily by the mnemonic vodka. We know vodka we drink orally. We do not take injection. Vodka oral pite. So these are oral penicillins. And from the name you can remember V stand for penicillin V. Penicillin V. The chemical name of penicillin V is phenoxymethyl penicillin. Penicillin V is phenoxymethyl penicillin. Then O for oxacillin. Remember all penicillins will contain cillin in the name. D is dicloxacillin. Cloxacillin. K is cloxacillin. And on MA we have 2 drugs, ampicillin and amoxicillin. So ampicillin and amoxicillin. So the first problem with penicillin was they were not effective orally. So we developed vodka. As vodka is a solution of every problem, so it was the solution of this problem also. So vodka penicillins are effective orally. Clear? Then coming to second problem. Second problem was penicillins were short acting. And the reason why they are short acting is they have rapid tubular secretion. So what we note, this is blood and this is kidney. So penicillins, they are very quickly secreted through the renal tubules. Quickly renal tubules can secrete them. So within 3-4 hours they go out. So the action stops. So if we are able to stop this tubular secretion, then they will remain in the blood. They can become long acting. And do you remember any drug which can inhibit the tubular secretion of penicillins? Yes, it was probenecid. So the first method of prolonging the duration of action is we can add probenecid. So when we give probenecid and penicillin together, then probenecid has higher affinity for those transporters, so it always go out. Penicillin cannot go out, it remain in the blood, so it become long acting. Yeah. Then second method we developed the depot preparations. Depot preparation means these are the preparations which will deposit somewhere in the body. So what we do, we attach some group with the penicillins like benzathine group or procaine group. So when we attached benzathine or procaine group with penicillin G, so what they do is they will hold the penicillin in the muscle. Like this is a muscle. We give benzathine penicillin G. So benzathine penicillin G, it will hold the penicillin in the muscle. That means when we give intramuscular injection, suppose we give 1000 molecules of penicillin G, benzathine penicillin G by intramuscular injection. Now they will stay in the muscle, all cannot come into blood. So out of 1000 molecules, only 100 molecules can come into the blood. 900 are stored in the muscle. Now out of these 100 molecules, they will produce the effect for 2-3 hours, and then they will be secreted out. Remember, only that molecule will secrete out which comes into the blood. So only 100 molecules go in 3 to 4 hours. After that, 100 more molecules are released from the muscle. They come into the blood, again they will be secreted out in 3-4 hours. So this will keep on happening, and the penicillins will become long acting. So we can use benzathine or procaine group to hold them in the muscles, depot preparation, and gradually they will be released. Clear? Now the question is, if you give benzathine or procaine penicillin G by intravenous route, then what will happen? So when we have given them IV, they have come into the blood. So they will again go out. So they will be short acting like every penicillin. So benzathine or procaine penicillin G, they are specifically made for intramuscular injection only. They cannot be given intravenously because there will be no advantage of giving them IV. Is it clear? So they are given intramuscular only. And benzathine penicillin G is longest acting penicillin. Okay. Then third problem was spectrum. Now if you see, we have two main type of bacteria, gram positive and gram negative. Gram positive include cocci and bacilli. Gram negative also include cocci and bacilli. Gram positive cocci, they mainly include SSP, Streptococcus, Staphylococcus and Pneumococcus. Streptococcus, Staphylococcus and Pneumococcus. Whereas gram positive bacilli, they include Bacillus, the name says bacilli, Bacillus, Clostridium, Bacillus, Clostridium, diphtheria causing organism, Corynebacterium diphtheria, and Listeria. The main bacteria, many others are there, but the main one, Bacillus, Clostridium, diphtheria and Listeria. Then gram negative cocci mainly include Neisseria. So Neisseria mainly two type, Meningococcus and Gonococcus. Gram negative cocci. The gram negative bacilli is a long group, big group. Enterobacteriaceae, all Enterobacteriaceae present here, including E. coli, Salmonella, Shigella, Pseudomonas, Klebsiella, and many organisms are there. So biggest group of organism, gram negative bacilli. Now penicillins, particularly penicillin G, it is effective against gram positive cocci and bacilli as well as gram negative cocci, but not effective against the biggest group, that means gram negative bacilli. So penicillin G is said to have narrow spectrum because the largest group of organism, they cannot be killed by penicillin G. So what we did, we developed newer penicillins which can kill gram negative bacilli also. So we have increased the spectrum, extended the spectrum. So these newer penicillins are called as extended spectrum penicillins. We have extended the spectrum of penicillins to cover gram negative bacilli also, and these you can remember from the name ACityMap. These are ACityMap penicillins, ACityMap. So from the name you can remember the map of a city is quite wide or quite extended. So these are extended spectrum penicillins. So A stand for same two drugs, ampicillin and amoxicillin. C is carbanicillin. T is ticarcillin. M is magillocillin. A is agilocillin. And P is piperacillin. So ACityMap penicillins. Now here comes one very important thing, which is the most dangerous gram negative bacteria. Yes, it is Pseudomonas. So very commonly the question asked, which penicillins are effective against Pseudomonas, which are not. So you can remember except A, CityMap is effective against Pseudomonas. Citimap is effective against Pseudomonas. That means carbanicillin, ticarcillin, megeloxilin, ageloxilin, piperacillin. They are effective against Pseudomonas. Very commonly question asked is, all of the following drugs are effective against Pseudomonas except. So we will discuss several drugs. Around 40-50 drugs we'll discuss which are effective against Pseudomonas. But if you see the questions which are asked which is not effective against Pseudomonas, they always change the 3 options which are effective, but the answer remains same, and that answer is almost always vancomycin. So probably examiner do not need to know or do not want to know which drugs are effective against Pseudomonas, but examiner want to know that vancomycin is not for Pseudomonas. In antimicrobial, at several places you need to remember which are not effective rather than which are effective. So one of the most important thing to remember here, vancomycin is not for Pseudomonas. Okay. So this was the third problem, spectrum. Then fourth problem was of resistance. Now if you see, suppose this is a bacteria, gram-positive bacteria. Suppose it is Streptococcus or Staphylococcus. When we give penicillin G, penicillin G comes and kills this bacteria. Then this bacteria had a meeting. They called a meeting, and in the meeting they discussed that some penicillin comes and kill our people. We will not tolerate this. We have to do something. So what they did, they kept these security guards. So now this penicillin, this bacteria, it has developed security guards, and they are waiting here with guns in their hand. So whenever we give penicillin G, the security guards will push the bullets and this penicillin G will be killed. And when penicillin G is not there, the bacteria will not be killed. So resistance will. So this method of development of resistance is by developing the enzymes which can break penicillins, and those enzymes are called as penicillinases. So if a bacteria develop penicillinase enzyme, then it can break penicillin. Structure will be broken, so bacteria will not be killed, so resistance will develop. And because penicillin is one of the beta lactam, so this enzyme is also called as beta lactamase. So beta lactamase is a broad term. It includes penicillinase, cephalosporinase and other drugs breaking bacteria. So beta lactamase or penicillinase. Now one question asked is, at which place on this structure beta lactamase work? If you see, this is the beta lactam ring and this is the second ring we discussed. Now the name tells beta lactamase means it will break beta lactam ring. So you need to identify which is the beta lactam, and that you can identify the structure. If that is the square structure, 4 carbon structure is beta lactam ring. So whichever point is given on this ring, at that point the beta lactamase will work. So options usually given are 1 point given on beta lactam ring and 3 point on second ring. So this will be the answer, the point which is on beta lactam ring. So beta lactamase will break the penicillin on beta lactam ring. Okay. Now coming back, now the bacteria has security guards. They have guns, and we also know that they have guns. So if we send our penicillin G alone, obviously it will be killed. So what we can do? What we do, we send this penicillin G by giving a bulletproof jacket. If penicillin G has a bulletproof jacket, now the bacteria will keep on shooting. But because of jacket, penicillin G is not harmed. So now it go in the bacteria and kill them. So we can reverse resistance. Okay? So this bulletproof jacket, it is known as beta lactamase inhibitor. The name says it will inhibit the enzyme beta lactamase inhibitor. Beta lactamase inhibitor. And the name of the beta lactamase inhibitors you can remember from CST. Clavulanic acid, sulbactam and tazobactam. A new beta lactamase inhibitor, avibactam, has been approved now. Avibactam. So these are bulletproof jackets. Now suppose at some place there is a war. battle has started, and at that place we throw the bulletproof jackets, will they kill the enemy? Obviously not. So if we want to kill the enemy, we want soldiers. Our soldiers should be there, and our soldiers are penicillins. So that means these beta lactamase inhibitors alone will not be effective. They must be given with penicillins. Okay? So common combinations which are asked in the exam: clavulanic acid is given with amoxicillin, sulbactam is given with ampicillin, and tazobactam is given with piperacillin. As you can easily remember, different soldiers will have different sizes, so different jackets will fit them. So according to the size, we have made these jackets. So in simple language, based on pharmacokinetics, we have made these jackets. Okay? So clavulanic acid with amoxicillin, sulbactam with ampicillin, and tazobactam with piperacillin. Clear? So this is one method of taking care of resistance. Then second method is, we know penicillin G can be killed by enzymes present in the bacteria or security guards by the bacteria. So what we do, instead of giving penicillin G, we will call Rajnikant. A hero will come, Rajnikant. So now no bullet can touch Rajnikant. So when we send Rajnikant, Rajnikant will evade all the bullets, go inside and kill the bacteria. Bullets cannot do anything for Rajnikant. So this type of penicillins, Rajnikant penicillins, they are not affected by the bacterial enzyme. So these penicillins are called as penicillinase resistant penicillins, or simply Rajnikant penicillins. So we have another method. We developed the drugs called as penicillinase resistant penicillins. Penicillinase resistant penicillins, in our language these are Rajnikant penicillins, and these penicillins you can remember as condom drugs. So just like condom protect from pregnancy, so condom drugs protect from penicillinase. Okay, so C stand for cloxacillin, O is oxacillin, N is nafcillin, D is dicloxacillin, O we have already done, and M is methicillin. So these penicillins are called as penicillinase resistant penicillins. That means even if penicillinase is present, it is not able to break the chemical structure of these drugs. Penicillinase resistant penicillins, condom drugs. Now out of these, the most important is to remember methicillin. The bacteria which are resistant to methicillin, they are labeled as MRSA, methicillin resistant Staph aureus. But special thing to remember, resistance to methicillin developed by a different method. The resistance to methicillin mainly develops by altered penicillin binding proteins. The basic logic is, when we give any antibiotic, penicillin group of antibiotic, any beta lactam basically, it may be penicillin, cephalosporin, carbapenem, any group of beta lactam antibiotic, they first bind to bacteria on the cell wall and then they will kill them. And that binding place is called as penicillin binding protein. Penicillin binding protein. Although the name is penicillin binding protein, but all beta lactams bind there. Okay. So bacteria, what they have done is they have changed that place. Penicillin binding protein is altered. So the antibiotic cannot bind, beta lactam cannot bind. So when it is not able to bind, it cannot kill bacteria. So resistance will develop. So resistance to MRSA occur because of change in target, or we can say altered penicillin binding protein. What is the special thing about this is, if the penicillin binding protein is altered, the final structure is altered, then no beta lactam will be able to bind. So that means almost all beta lactams, they are ineffective against MRSA. There is one exception we will discuss later on. 5th generation cephalosporins are still effective, but apart from that, all other beta lactams, they are ineffective against MRSA. So this is the second area where you need to remember not effective. The question asked is, all of the following are effective against MRSA except. We'll see many drugs which are effective against MRSA, but the answer almost always is one of the beta lactams. Remember, beta lactams are not effective against MRSA. One exception, 5th generation cephalosporins. Okay, so this is the fourth problem, resistance. Then the last but the very significant problem is allergy. Penicillins can cause allergy. They can even cause anaphylactic shock. This is the problem we are not able to handle till now. Means any penicillin, whether it is old or it is new, can cause allergy. So how we can prevent the anaphylaxis or death of the person? Very good. So we need to test it for allergy and then give. And important question is, by which route you do the testing, allergy testing? Yes, it is by intradermal route. So what we do? We give very small amount of the penicillin intradermally. Remember intradermal injection given at 0 degree angle, almost horizontal to skin. So we give intradermal penicillin, small amount, observe for half an hour. If there is any reaction at that place, means person is sensitive, allergic. So we will not give. And if there is no reaction, we can give. Now second thing, if allergy occurred to one penicillin, obviously that is contraindicated. But there is significant cross allergy between different penicillins. Significant cross allergy between different penicillins means if a person is allergic to ampicillin, obviously it is contraindicated, but if we give piperacillin, allergy is likely. So piperacillin is also contraindicated. So if person is allergic to one penicillin, all penicillins are contraindicated. Now not only penicillins, all beta-lactams are contraindicated because there is significant cross allergy between different beta-lactams. And the major exception you need to remember, monobactams do not show cross allergy. Monobactams do not show cross allergy. So monobactam may be used in these persons. We need to test separately for monobactams. Okay? So monobactams do not show cross allergy. Okay, so these were the 5 problems of the penicillins and their solutions. Now we can move to uses of penicillins, particularly uses of penicillin G we will discuss. And these you can remember from the mnemonic. Last mango. Last mango. L for listeria. A for actinomycosis. S is syphilis. T is tetanus. M is meningococcus. AN is anthrax. And GO is gonococcus. Penicillin G used for last mango. So we will discuss these one by one in detail. Listeria. Penicillin G were originally used, but now the drug of choice for listeria is ampicillin. Drug of choice for listeria is ampicillin. Actinomycosis, penicillin G is still a drug of choice. Syphilis, penicillin G is a drug of choice. The treatment of syphilis you need to remember in detail with the doses. Syphilis can be divided into primary syphilis, secondary syphilis, and latent syphilis. Latent syphilis may be early latent syphilis or late latent syphilis. Then there may be tertiary syphilis. The treatment of these, all of them, the drug of choice for syphilis is benzathine penicillin G. Benzathine penicillin G is a drug of choice for syphilis. Primary, secondary, tertiary, latent, everywhere. The difference is for primary, secondary, and early latent syphilis. First case, the drug of choice for benzathine penicillin G, it is given as a 2.4 million unit injection by intramuscular route, only one injection, single injection. So for primary, secondary, and early latent syphilis, single intramuscular injection of benzathine penicillin G, the dose is 2.4 million units. Then late latent syphilis and tertiary syphilis except neurosyphilis. The drug of choice is same benzathine penicillin G. The route of choice is same intramuscular. The dose is same 2.4 million units. Everything is same. The only difference is we need to give 3 doses, one every week. So 2.4 million units today, then next week, then next week. So 3 doses, 2.4 million unit each for 3 weeks, once every week. Okay? Then there is neurosyphilis. Now, very important thing to remember, benzathine group cannot cross the blood-brain barrier. So, in a neurosyphilis, we cannot add benzathine group to the penicillins. So, for neurosyphilis, we need to give aqueous penicillin G. Aqueous penicillin G simply means without benzathine or procaine group. So, we give penicillin G. And because penicillin G is short-acting, so we need to give several times a day. And that treatment is continued for 10 to 14 days. So benzathine penicillin G is long acting, we can give once a week, whereas this is given daily or several times a day in fact. Okay? So take home message is primary, secondary and early latent syphilis, single injection of benzathine penicillin G. Late latent and tertiary syphilis, 3 injections of benzathine penicillin G. But in neurosyphilis we give penicillin G without benzathine group and that is given several times a day for 10 to 14 days. Okay, so this is about syphilis. Then coming to tetanus, the drug of choice for tetanus is penicillin G. In some books metronidazole is also mentioned, but penicillin G will be preferred. So penicillin G preferred over metronidazole. Then for meningococcus, meningococcus is causative organism for meningitis. We will discuss both the aspects, the treatment as well as prophylaxis. Now a person comes to the hospital with meningitis and we are suspecting that it can be meningococcal meningitis, but we are not 100% sure. So what we will do? We will take the CSF sample, send it to the laboratory for culture and sensitivity. So culture the bacteria which is causing the organism, causing the infection, and do the sensitivity testing which antibiotics will respond to, antibiotic which will be effective. But till the time result come, which will take usually 48 hours or more, we have to start some antibiotic. So that treatment is known as empirical therapy. Empirical therapy means a broad spectrum therapy. It should cover meningococcus obviously, but it should cover other likely organisms also like Haemophilus, because we are not sure it is meningococcus. So a broad spectrum drug is given and that is ceftriaxone. So for meningococcal meningitis, ceftriaxone is given. Okay. But if there is definitive treatment like laboratory result has come and we are 100% sure that it is meningococcal meningitis, then the treatment of choice is penicillin G. So that therapy is called as definitive therapy. So empirical treatment is ceftriaxone, definitive treatment is penicillin G. Now meningococci, when the infection has occurred in large population, outbreak has occurred and we want to prevent that. So for prophylaxis, we have 3 drugs which can be used. One is rifampicin. Second is ceftriaxone. And third is ciprofloxacin. So 3 drugs can be used. Previously, rifampicin was the drug of choice. But now it has been found that most meningococci, they are starting to develop resistance against rifampicin. So rifampicin is not reliable now. So nowadays rifampicin is less often used because of resistance. On the other hand, ceftriaxone is the most effective drug for prophylaxis of meningococcal meningitis. Most effective. It is most effective, but the problem is it is injectable drug. It cannot be given orally. So if we want to prevent meningococcal meningitis and we want to give to 10,000 people or 100,000 people, so then giving injection is practically not a solution. So we want oral drug for that. Okay? So meningococcal meningitis, ceftriaxone, although it is most effective drug for prophylaxis, but practically it is not possible. It's a problem, and it is safe in pregnancy and children. It's very important. Ceftriaxone is safe in pregnancy and children. Then ciprofloxacin, if we see, it is little less effective than ceftriaxone, but it is quite effective. But the advantage is it can be given orally. Because it can be given orally and it is quite effective, so it is a drug of choice for mass chemoprophylaxis. Mass chemoprophylaxis, we will prefer ciprofloxacin because it can be given orally. But ciprofloxacin is contraindicated in pregnancy and children. So if there is meningococcal meningitis we want to prevent in pregnant female or in children, we have to give ceftriaxone. Okay? So if we quickly revise this, drug of choice for empirical treatment of meningitis is ceftriaxone. Drug of choice for definitive treatment of meningitis, meningococcal meningitis, is ciprofloxacin. Drug of choice for mass chemoprophylaxis of meningococcal meningitis is ciprofloxacin. And most effective drug for meningococcal meningitis prophylaxis is ceftriaxone, and drug of choice for prophylaxis in pregnancy and children is ceftriaxone. Okay, so after meningococci, penicillin G is used for anthrax, and again for anthrax some books say penicillin G and some books say ciprofloxacin. So penicillin G is preferred over ciprofloxacin for treatment of anthrax. Then coming to gonococci. Initially penicillin G was a drug of choice for gonococci, but now most of the gonococci have become resistant to penicillin G. So penicillin G is no longer used for gonococci. Instead, nowadays ceftriaxone is a drug of choice for gonococcus. So we have made the mnemonic. At that time it was used, last mango. But because we have said last mango, we have said go, so go has gone. So penicillin G is not used for gonococci now. Last man it is used. For gonococci, if you see gonococcal urethritis, major causative organism for urethritis. So if there is gonococcal urethritis, the drug of choice is ceftriaxone. Ceftriaxone. But if there is non-gonococcal urethritis, the drug of choice is azithromycin. Azithromycin is drug of choice for non-gonococcal urethritis. And if there is mixed gonococcal as well as non-gonococcal urethritis and we want to give a single drug, it is azithromycin because it can treat both of them. Okay, so these are the important uses of penicillin G. Okay. So we completed the first part of beta-lactam antibiotics, that means penicillins. Now we can discuss the second group of beta-lactam antibiotics, which are cephalosporins. Cephalosporins. These are divided into different generations based on their spectrum of activity. So classically we divided them into 4 generations: first, second, third, and fourth. But recently we have introduced a 5th generation also. Now if you want to remember the spectrum broadly, you can remember that first generation will be like penicillins. Just like penicillins, first generation are mainly effective against gram-positive bacteria. But as we move from first to second to third to fourth generation, activity against gram-negative keep on increasing. So second generation is also effective against gram-negative, third also, fourth also, but activity keep on increasing. Fourth generation is highly active against gram-negative. Then special thing to remember, third generation has very good activity against gram-positive also. So third generation are the broad spectrum activity against both positive and negative. And second generation, special point to remember, they are effective against anaerobes also, anaerobic bacteria. So some of the second generation drugs are effective against anaerobes also. So first mainly positive, fourth mainly negative, third both positive and negative, and second anaerobes. Then the recently formed 5th generation cephalosporins, they are active against MRSA. Remember, this is the exception. No beta-lactam is effective against MRSA, but these are effective. Fifth generation cephalosporins. Okay. Now coming to drugs. Now all these cephalosporins, they usually contain in the name ceph for cephalosporin. So first of all, write down the names, which generation contain which drugs, and then we will try to discuss how to remember that. First generation, the drugs include cefazolin, cefalaxin, cefadroxil, cefalothin, and cephaloridin. First generation. Second generation drugs include cefaclor, cefuroxime, cefoxitin, cefmetazole. Important second generation drugs. Then third generation, we have plenty of drugs in this group. These include cefixime, ceftriaxone, cefoperazone, cefotaxime, cefpodoxime, ceftazidime, ceftibuten. The important third generation cephalosporins. Then fourth generation, we have only two drugs in this category. These include cefepime and cefpirom. Cefepime and cefpirom are fourth generation, and the fifth generation cephalosporins, they include ceftaroline and ceftiviprole. These are fifth generation cephalosporin. Now coming to our main question, how to remember, which is first generation, which is second generation, how to remember. Now remembering them is quite easy. If you see first generation cephalosporins, after the ceph, all are starting from ceph. After the ceph, A is present. That means the drugs which start from cepha, they are first generation. All drugs starting from cepha are first generation. Important exception you need to remember is cefaclor. Cefaclor start from cepha. That means after the ceph there is A. A means first letter. So it is not first generation. Rest all drugs starting with the cepha are first generation. Okay. So we have to see in sequence. First we'll see whether cepha is present or not. If cepha is present, it is first generation. If it is not present, then we will go to second category. And second thing we will see is whether the name contain pi or not. If the name contains pi, it is fourth generation. So see cepha, cepha is not there. Then see name contains pi or not. If pi is present, it is fourth generation. Cefpime, cefapirom. Now if pi is also not present, cepha is not present, pi is not present, then see whether role is present in the name or not. If the name contains role, it is fifth generation. Fifth generation. So we have seen in sequence cepha, then pi, then role. Now if all three are not present, then we will see whether the name contains me, 1 or 10 at the end. If the name ends with me, 1 or 10, then it will be third generation. Like we see cefixime, me, cefotaxime, me, cefpodoxime, me, ceftazidime, me, or 1, ceftriaxone, cefoperazone, they are 1, ceftibuten, it is a 10. So me, 1, 10. These are third generation cephalosporins. Again, one exception to remember, it is cefuroxime. The name end with me but it is not the third generation, it is the second generation. Clear? And all remaining will be second generation cephalosporins. So quickly revising the nomenclature, how to remember. We discussed, first see whether the name start with the CEPHA or not. If it start with the CEPHA, it is first generation. If it is not starting with the CEPHA, then see pi in the name. If pi is present, it is fourth generation. If pi is not present, then see role. If role is present, it is fifth generation. If role is also not present, then see the end, whether it is ending with me 1 or 10. If it is ending with me 110, it is third generation, and if it is not ending, then it will be second generation. Two exceptions: cefaclor, it is not first, it is second generation, and cefuroxime, it is not third, it is second generation. Clear? So these are the methods to remember the names of cephalosporins with their generation. Okay, so now we can go to special point about some cephalosporins. Very important question asked: which cephalosporins are secreted in bile? The first question is, what is the meaning of this? The meaning is, these cephalosporins, when they come in the bile, normally most of the beta lactams, they are excreted by kidney. So when they are excreted by kidney, they will require dose adjustment in renal failure. But if a drug is secreted in bile, that means through the bile it will be coming to GIT. Bile duct opens in the duodenum. So through the GIT it will be excreted out in the feces. That means even if kidney do not work, we do not worry, because we have another method through which drug can go out. So the drugs which are secreted in bile, they are safe in renal failure. Clear? So among the cephalosporins, you can remember one cephalosporin is secreted in bile. One cephalosporin is secreted in bile, and these ceftriaxone and cefoperazone. I was saying one cephalosporin is secreted in bile, but I have written two. Why I am saying again and again one cephalosporin is secreted in bile? I mean that the drugs which end with one, they are secreted in bile. So ceftriaxone and cefoperazone, they are secreted in bile. Okay? And about ceftriaxone, the important thing is, if we give in large doses, it will be secreted in bile in so much amount that it can result in a side effect called as biliary sludge syndrome. So ceftriaxone is associated with biliary sludge syndrome. Okay, so if a drug is secreted in bile, means it is safe in renal failure. Now here, not only among cephalosporins, the MCQ is very commonly asked, which antimicrobial is secreted in bile, or we can say which antimicrobial is safe in renal disease. Okay? So you need to remember all of them, and you can remember them as safe in the renal disease. Safe in the renal disease. If they are secreted in bile, they will be safe in the renal disease. So from the safe, you can remember it is talking about cephalosporins. And which cephalosporins? Those which end with 1, like ceftriaxone and cefoperazone, ending with 1. Then T stand for tigecycline. Tigecycline. R for rifampicin, used in TB. E is erythromycin. Erythromycin. N is nafcillin. Nafcillin. A is ampicillin. L is lincosamide group of drugs. The only important drug in this group is clindamycin. Clindamycin. And D for doxycycline. So these are the important drugs which are secreted in bile. So they are safe in renal disease. They do not require dose adjustment in renal disease. Okay, so that is about the first important thing, which cephalosporins are secreted in bile. Those which end with 1, they are secreted in bile. Then second thing you need to remember, which cephalosporins are effective against Pseudomonas. Pseudomonas. Remember, Many drugs are effective against Pseudomonas, but you need to remember which is not effective. Which is not effective? Yes, vancomycin is not effective. So among the cephalosporins which are effective, these are cefoperazone, ceftazidime. These both are third generation. Then we have cefepime and cefpirone. These are fourth generation. These are effective against Pseudomonas. And if you see the name, you can find out of the 4, 3 contains P in the name. So P stands for Pseudomonas. So cephalosporins containing P in the name are effective against Pseudomonas. But the problem is the one which do not contain P in the name, that means ceftazidime, it is most effective cephalosporin against Pseudomonas. Ceftazidime is most effective. And you can remember from the name, its name contain Jiddi. Pseudomonas is an organism which is resistant to many drugs. बट ये वाली जो सेफेलोस्पोरिन है सेफ्टाजिडिम, ये जिद्दी है, ये कह रही है मैं नहीं छोड़ूंगी सुडोमोनास को, तो सेफ्टाजिडिम बहुत जिद्दी है, तो सबसे ज्यादा इफेक्टिव ड्रग अगेंस्ट सुडोमोनास. अदर ड्रग्स विच कंटेन पी इन द नेम, दे आर फॉर सुडोमोनास. ओके. Then certain cephalosporins, they can cause disulfiram like reaction. If you remember from the CNS, if a drug inhibit aldehyde dehydrogenase, it can lead to disulfiram like reaction if a person takes alcohol. So basically these interact with alcohol, and the drugs causing disulfiram like reaction include cefoperazone, moxalactam, cefotitan, and cefoxitin. Remember, moxalactam is also a third generation cephalosporin. This is not starting with ceph, so you do not get confused. So cefoperazone, moxalactam, cefotitan, cefoxitin, they can cause a disulfiram like reaction, so they are avoided in a patient who are alcoholics, and whenever they are given, person is instructed not to consume alcohol. Okay. Then we have fourth thing, some cephalosporins can cause hypoprothrombemia. Hypoprothrombemia means they can decrease prothrombin level, and when prothrombin level is reduced, that increase the risk of bleeding. So these should be avoided in patient with bleeding tendency like hemophilia. And incidentally, these are the same 4 cephalosporins which cause disulfiram like reaction. They contain a chemical structure called as methyl thiotetrazole, so that may be responsible for these problems. So disulfiram like reaction and hypoprothrombemia, these cephalosporins are involved. And if you see 4 points which we discussed, all of the 4 contain one cephalosporin, which is cefoperazone. Cefoperazone is secreted in bile. Cefoperazone is effective against Pseudomonas. Cefoperazone can cause disulfiram like reaction. Cefoperazone can cause hypoprothrombemia. Clear? So it is present in all. So that means if in the exam you do not remember anything and the option contains cefoperazone, close your eyes, mark that option. Most likely that will be right. It will fit somewhere. Okay? So these are the important points regarding the cephalosporins also. Okay. So now we will move to the third group of beta lactams, which are called as carbapenems. Carbapenems. The first carbapenem which was formed was imipenem. Imipenem. This drug is highly effective against most of the organisms. Means in the laboratory when we tested, it can kill most of the gram positive bacteria, most of the gram negative bacteria, including Pseudomonas, and it can also kill the anaerobic bacteria. So that means it has very wide spectrum. It can kill almost any bacteria. But the problem is, when we tested this drug in humans, then it did not kill even one bacteria. No bacteria was killed. धोखा ही दे दिया बिल्कुल. In the laboratory it was killing every bacteria, but in the body it was not killing any bacteria. Then the research was made why this happened. So we came to know that our kidney produce an enzyme called as dehydrogenase dehydropeptidase. Kidney produce an enzyme called as dehydropeptidase, and this enzyme breaks imipenem. So that means in the body it is already broken. Because it is broken, that's why it is not effective. So then we thought that if we inhibit this enzyme, then imipenem will not be broken. So then it can be utilized, and yes, it could be utilized. So we developed a drug which can inhibit this enzyme, and that drug is called cilastatin. Cilastatin. So imipenem, it is always given with cilastatin. With cilastatin. So cilastatin will inhibit the breakdown of imipenem, and now it can kill almost all bacteria. Clear? And another important thing to remember, the name of cilastatin end with statin, but it is not a HMG-CoA reductase inhibitor. Remember, all the HMG-CoA reductase inhibitors which we commonly say statins like atorvastatin, simvastatin, pravastatin, their name end with statin, but before statin they contain VA, Simva, Rosuva, Prava, Atorva. So if the name contains vastatin, only then it is a statin. Clear? So cilastatin is not a statin. It inhibits dehydropeptidase enzyme. Clear? Now second thing, major side effect of imipenem is seizures. Imipenem can cause seizures, so it is contraindicated in epileptic patients. Imipenem is contraindicated in epileptic patients. Now after making imipenem, we developed newer carbapenems. But in the newer carbapenems, we kept this thing in mind, these two problems in the mind. Number one, that imipenem is broken by dehydropeptidase. So all the newer carbapenems which we made, they were resistant to dehydropeptidase, so they can be given without cilastatin. Imipenem is always given with cilastatin, whereas all newer carbapenems can be given without cilastatin. Number two, we make sure that they do not cause increased incidence of seizure as compared to imipenem. So that means all the newer carbapenems, they have much lesser risk of causing seizures as compared to imipenem. Okay? And the name of the carbapenems, they will end with penem, like imipenem. Okay? So we have meropenem, we have ertapenem, we have doripenem, and we have ferropenem. So all these drugs have two important properties. One, they can be given without cilastatin, so cilastatin is not required, and second, they have lesser risk of causing seizures. Or you can simply say, among the carbapenems, the highest risk of seizures is with imipenem. Okay, and the last carbapenem, ferropenem, this is the only carbapenem which can be given orally. All other carbapenems are injectable. Ferropenem can be given orally. And in fact, from the name you can remember, its name should actually have been laropenem. Had the name been laropenem, then we would have mnemonic ORAL, oral. Okay? But the name R hard lug, it is not laropenem, it is ferropenem only. But ferropenem can be given orally. Clear? Now carbapenems, they are effective against a bacteria producing ESBL. Now we'll try to understand. We discussed that penicillins, they are broken down by beta lactamase. Okay? So they are broken down by an enzyme. Then second thing, we know that penicillins have narrow spectrum. Okay? So what we did to counter the narrow spectrum? We made broad spectrum penicillins. That means which can kill large number of bacteria. The same thing was once heard by the bacteria. So bacteria thought that humans have done such a thing that one drug can kill many bacteria. Then why don't we do such a thing? So we will develop such a bacterial enzyme which can kill not only penicillin but many other drugs also. So that enzyme they developed, and that was named as extended spectrum beta lactamase. So as the name tells, the spectrum of beta lactamase is extended. So this enzyme not only break penicillins but can also break cephalosporins and other drugs. Another important thing, ESBL, it not only break beta lactams but it can also break non-beta lactams like fluoroquinolones, aminoglycosides. So it can kill large number of antibiotics. So it is resistant to many antibacterials. So the bacteria which most commonly harbors ESBL is Klebsiella. So that means the Klebsiella which has ESBL, it is resistant to most of the antibiotics. But this ESBL has two limitations. Number one, this cannot break carbapenems. It cannot break carbapenems. It can break most of the drugs, but it cannot break carbapenems. And second, this can be inhibited by beta-lactamase inhibitors. That means if some person comes with bulletproof jackets, then it cannot do anything. So we utilize these two limitations for treatment. So carbapenems, because it cannot break carbapenems, so carbapenems became the drug of choice for ESBL producing bacteria. So any bacteria which produce ESBL, carbapenems will be drug of choice. And second, we can utilize piperacillin plus tazobactam for this ESBL producing bacteria. Remember, piperacillin is preferred because piperacillin is effective against Klebsiella, and tazobactam will inhibit the enzyme ESBL so that piperacillin can kill the bacteria now. Clear? So this is the solution for ESBL. Now the bacteria also came to know that humans have found the solution to ESBL. So what it did, it produced another enzyme which do not have limitations of this ESBL. That means it produced a newer enzyme which can even break carbapenems, and which is not broken by, which is not inhibited by bulletproof jackets. So that newer enzyme is known as NDM. It was first isolated from a patient from New Delhi. So this was named as New Delhi metallo-beta-lactamase. So what is the special property of New Delhi metallo-beta-lactamase? Like ESBL, it can break most of the antibiotics. But unlike ESBL, it can break carbapenems also. It can break carbapenems also. And unlike ESBL, it is not inhibited by beta-lactamase inhibitors. That means it can break most of the antibiotics, and it will not even be stopped by bulletproof jackets. So that means the bacteria which possess NDM, New Delhi metallo-beta-lactamase, it is almost immortal. So that bacteria was very famous with the name superbug, which is resistant to most of the antimicrobials. But later on we found the solution for this also, and the drug which can kill this bacteria containing NDM, that drug is called colistin. Colistin. Clear? So these are the important points regarding the carbapenem group of drugs, the third group of beta lactams. So now we will move to number 4 group, which is called monobactams. Monobactam. We have only one drug in this category, which is called as aztreonam. Aztreonam. Now from the name you found, monobactam, the name contains a mono. That means they have only one ring. This is just to remember, not the reason. They contain only one ring. They do not contain the allergy causing ring. So aztreonam, it can be used if it do not cause cross allergy. Cross allergy. So that means if a person is allergic to other beta lactam, we can still use aztreonam. Second important point to remember, it is effective only against gram-negative bacteria, only gram-negative. And remember, this includes Pseudomonas. So this is also effective against Pseudomonas. It is not effective against gram-positive bacteria. So if you note that it has two properties which are opposite to penicillins. You know, penicillins cause allergy. This do not cause. Penicillins are mainly for gram-positive. It is not effective. It is only for gram-negative. Okay? So when penicillins came to know that in our group, beta lactam group, one drug has come which has properties opposite to us. Penicillins are for positive, it is for negative. Penicillin for causing allergy, this is not causing. So penicillins इसके पास गई, penicillins इसके पास गई और इसको जाके बोलते कि अजी तेरा नाम तो बता. तो from that day we kept the name as अजी तेरा नाम. Okay? So अजी तेरा नाम, aztreonam, it is opposite to penicillins, you can remember. Clear? So these are the important points regarding the beta lactam antibiotics. Okay, so now we are left with the last drug which inhibits cell wall synthesis. It is vancomycin. Vancomycin. Chemically, vancomycin belongs to a group called as glycopeptide. So So it is a peptide group of antibiotics. So from the name you can remember its name is ending with in. That substances whose name end with in, like insulin, oxytocin, angiotensin, they are peptides. So it is also a peptide, vancomycin. Okay. Now special points about vancomycin to remember. Vancomycin is not effective orally, but the reason is different. Penicillins were not effective because they were broken by acid, but acid cannot do anything to vancomycin. Still it is not effective because it is not absorbed. It is a big chemical structure, it cannot be absorbed through GIT, that's why it is not effective, but it is not broken by acid. Then second, because it is not effective orally, we need to give IV, and when we give it IV, it has high potential to release histamine. Vancomycin can release histamine, and that histamine will cause vasodilation, and when vasodilation occurs, the person will appear red. Okay. So the side effect is known as red man syndrome. Very common side effect of vancomycin. There will be flushing of the face, redness of the face, called as red man syndrome. Then third, vancomycin is nephrotoxic, and vancomycin is also ototoxic. Vancomycin is nephrotoxic and it is ototoxic. And we discussed several times vancomycin is not effective against pseudomonas. Vancomycin is not effective against pseudomonas. Okay. So till now what we are doing, like a typical Indian mother-in-law, टिपिकल सास की तरह हम सिर्फ नुक्स निकालते जा रहे हैं, ठीक, किसको ओरल नहीं दे सकते, रेडमैन सिंड्रोम करता है, किडनी खराब कर देता है, सूडोमोनास में काम नहीं करता, क्लियर. सो ऑल दी प्रॉब्लम्स वी आर डिस्कसिंग सो फार. So now let us discuss some advantage also, some uses also. So vancomycin is a drug of choice for MRSA, methicillin resistant staph aureus. Vancomycin is a drug of choice for treatment. But be very careful if they ask what is a drug of choice for preventing MRSA infections. Obviously when we want to prevent, then we will not want injectable drug, we don't want IV, we want local drug. So drug of choice for prophylaxis of MRSA is mupirocin. Mupirocin or bacitracin can be used. Particularly those people who have nasal carriages, they can transfer the MRSA to other people, they are asymptomatic, so we can use mupirocin or bacitracin to them. Clear? Second, vancomycin is also used in pseudomembranous colitis. It is a drug of choice for pseudomembranous colitis now. We will discuss pseudomembranous colitis in detail in another video. Here you remember it is a drug of choice for pseudomembranous colitis, but for pseudomembranous colitis, second thing to remember, it is given orally. Vancomycin is given orally for pseudomembranous colitis, the only indication where it is given orally. But just now we said that vancomycin is not effective orally. Now we are saying it is given orally. So what is the catch here? Clear? In pseudomembranous colitis, where the infection is, it is in the GIT, colon, and vancomycin is not effective orally because it is not absorbed. So when we give it orally, it is not absorbed, it is good, it will go to colon, kill the bacteria. So it is just like a local route in this case. Okay? Vancomycin is given orally for pseudomembranous colitis. Clear? So these are the important points regarding the vancomycin. Okay? Now we have some newer drugs related to vancomycin, that means the other glycopeptides. The other glycopeptide group of drugs apart from vancomycin, these include teicoplanin and many drugs which end with vancin, like oritavancin, telavancin, dalbavancin. So vancin, from the name you can remember, they look like vancomycin, vancomycin like drugs. Yeah. So like vancomycin, these are mainly for gram-positive bacteria, including MRSA. Yeah. But the advantage of these is they do not cause red man syndrome. These drugs do not cause red man syndrome, unlike vancomycin. Yeah. So that, and they are little longer acting than vancomycin. Clear? So these are the important points regarding the drugs acting on cell wall. Thank you.